So next we're going to move into our approaches to meeting meaningful use too. And we invited two guest speakers to join us today to share their approaches, one from the provider perspective, one from the hospital perspective. And our first one is Sandy Rondeau. She's a practice administrator at the lung specialist in Merrimack Valley in Lowell, Massachusetts. Lung specialist is a well-established pulmonary critical care and sleep medicine private practice serving the greater Lowell area. Sandra successfully implemented a fully functional electronic health record in July 2005, was an active member of the Physician Hospital Organization's selection committee, encouraged community participation by providing on-site, hands-on visits to the practice, and continues to be proactive in moving the practice and community towards MU2. Sandra has worked in the healthcare field for over 30 years and a member of the Professional Association of Healthcare Office Management. So with that, Sandra, perhaps you can share with us what you're doing at Lung Specialists in Merrimack Valley.
We are utilizing eClinicalWorks version 10, which is a comprehensive electronic health record and practice management system. Along with their comprehensive EHR, we are also utilizing their patient portal, and we are utilizing their peer-to-peer, which stands for physician-to-physician communication. We activated actually the peer-to-peer back in 2010, and I'll talk a little bit more about that. We also began exchanging with a non-ECW physician who is actually using EHR called ComChart through Join the Network or Peer-to-Peer Open, which is an open free platform for providers. In the fall of 2012, we sort of thought a little bit beyond physicians because as a specialist, oftentimes you don't refer to another physician. So we thought about where do we send our patients. Because we're a pulmonary and sleep practice, which is a big part of our outpatient practice, we tend to send a lot of patients to durable medical equipment companies for oxygen and for CPAP. So in the fall of 2012, I really concentrated on working with our vendor to allow key DME providers who I thought could handle the security around having access to the information electronically through the peer-to-peer open to come aboard. In April of 2013, I was hesitant, but I did make the move to the cloud. So I let go of my in-house server and all the security that comes with having that in-house and let it go out to the cloud. I'm happy to say a year later, I am very satisfied that I made that transition. This spring, I applied with eClinicalWorks for our direct address so that we can move to the next level of exchanging information with providers with other EMRs. Our PHO is actually actively working with eClinicalWorks as a vendor. They happen to have a big presence here in this area, so the PHO is also working with them for that interoperability piece. So I'll talk a little bit about what we've done for the VDT, as people call it. Took me a while to get used to that. We also have an ID physician here, so when people said VDT, I sometimes thought of diseases. But for that view, download, and transmit, back in November of 2013 within our EHR, we have the ability to change the settings. So everyone was always hesitant in the specialist world to let results go out there for many reasons, because most of our results are not routine screenings. So we had that sort of everything by default was don't publish to the portal. So we had to let go of that. We changed that in November 2013. We're allowing things to publish to the portal automatically. It's taken a lot of education, both to our providers and our clinical staff, to let them know the importance of posting a result with information that's actually meaningful to the patient. So you want to make sure if you're posting a result that's not a routine screening and it's got a simple negative positive result, that you put some information along with that result so the patient can understand it. I also stress to all the physicians and staff that the hospitals, and you'll hear a little bit about that, also have to meet some of these measures. So the hospitals are starting to release information as well. So you may need to deal with the fact that your patients are getting information before you've even released it to them because it's been released by the hospital to them. So you want to think about that and how you might want to handle those calls inside your facility, sort of a workflow process. We started to let the patients know, so every time my office happens to be outside, right outside my checkout workstation. So when the physicians bring the patients and I hear them go, we're going to call you or call me, you know, sometimes I'll go up and go, oh, Mrs. Smith, you're enabled on the portal. So Dr. Lynn, you know, instead of having Mrs. Smith call Mrs. Smith, you're comfortable with replying to us via the portal. We've started to do that over the, you know, the past, just recently, the past couple of weeks. And what I'm hoping is that that's going to prompt the patient when they get that email, your physician has posted a message, it's going to prompt them to log into the portal and look around. So now they start looking around and they start viewing things. So now they've kind of met your V part of your VDT. They are viewing. So you've met one portion of that. I've seen the numbers inch up a little bit. So we're trying to hit sort of that percentage, that 5% they're looking for, and I'm almost close to 3. So I'm hoping we can meet 5. So we're encouraging staff. I'm encouraging staff when patients call. Let the patients know ahead of time that the provider is going to reply via the portal, working really hard with my providers to do that. So that's sort of how we're prompting people. Now, if that should fail, my other recommendation is I'm going to enter all patients who submit information to us via the portal. I'm going to enter them in a drawing for a free iPad, hoping maybe that'll pique some interest. So I'm going to watch the numbers, and we kind of laughed about that and put it to the side burner, but that may be a reality. That might be what it takes for patients to sort of go in and look around. The other thing that we're doing is eClinicalWorks also has a HILO application, and you'll sort of see that on the slide if you want to check that out. That's also a way for patients to take their different portals, if other portals can belong to HILO besides eClinicalWorks portal. Take those portals and tie them together either on their computer or their cell phones so that they can have one single login, username and password, and tie all those portals together. Because I think some of you will agree with me. I think patients are going to get sick of having 3, 4, 5 portals and everybody's forcing information. A lot of username and passwords to remember. So the HILO app, I'm actually going to play with it. I now have 2 portal accounts personally from 2 of my physicians. So I'm hoping to play with that in the next month and see if I can tie those accounts together and see if it works a little more seamlessly there. So as far as that's kind of my summary of the VDT. Now if we talk about transition of care, this is a big one for specialists. So I did a little bit of digging before this seminar, and I have confirmed, at least with our EHR vendor, that if you are a specialist and you are electronically submitting or faxing your consult note to the primary care physician, you will receive credit under Measure 1, because Measure 1, you can be sending that information in any format. So you can be faxing it or electronically submitting it in Measure 1. And again, as was mentioned earlier, keep in mind that it's a transition of care or referral. So specialists panicked over this a little bit because they thought they were going to have to be doing all these referrals, which they don't do because they usually send it back to the PCP. But it's really you're transitioning the patient's care from you as the specialist back to the primary care physician. Thus, you're supplying the primary care physician or whoever the referring physician was your consultation note. So that will count. The other thing to do as a specialist, again, I mentioned a little earlier, look beyond traditional providers or your traditional referrals. Think about where you send your patients. Do you refer them to other entities? Again, for us, we've got that durable medical equipment piece. We also have dental providers that we may refer to for physicians to get dental devices for sleep apnea. So think about beyond providers, where do you transition your patients to? For those providers, you can set up outgoing referrals, and you can send it via fax or electronically if you want to get those providers of care to join the network, the peer-to-peer open network. It's a free platform, and you can exchange information that way. That has worked, I can't tell you how well, for our durable medical equipment companies. Those that I've allowed to come aboard cannot thank me enough. It's made a big difference in their workflow. So think about that. The other thing that I would say is, again, it's a balance. And so as you go through these measures, you try to set things up so that you're transitioning sort of as Al stated, you're transitioning to meet the objective, but you got to find a balance initially to sort of meet the objective to get through your meaningful use attestation, but then you're going to build upon it. So you're not going to be done just here. You're going to be building upon it. And when you're talking about transition of care, I'm hoping that both primary care physicians and specialists are training the staff. The biggest roadblock we've run into here in the community is that providers are sending information through peer-to-peer as part of their workflow. So instead of faxing, they're sending it electronically. But unfortunately, it's sitting at the primary care office somewhere because nobody knows how to retrieve it, or it's sitting at the other provider, the referring provider, because nobody knows how to retrieve it. So this is not just a physician function. All staff members should have access to the information that's coming and going electronically. All staff members should be trained on how to pick it up, how to import it into your system, and how to use it. There's a nice CCR CCD portion to that where we can import current medications and allergies. Make sure your staff is trained, because I go out to offices, I'll go to train them, I look under their information where it should be coming in, and there'll be 50, 60 records sitting there from 6 months ago. No one even knew they were there. So it's really important to train the receiving side where that information is coming and how to import it into your system. And again, look, this is long-term, this is not short-term. Like Meaningful Use Stage 1, we all scrambled to sort of meet the objectives. Now, and as we go forward with Meaningful Use Stage 2, it will get easier, and we'll sort of expand upon it and keep moving forward and keep making the workflow better. I'm a big believer. I know a lot of us have heard with Meaningful Use the term checkbox medicine. I'm a big believer that although we have to meet these mandates, they are required, that if you really look at your office workflows, that at least you can truly make them meaningful within your practice. So you want to be putting information out that means something to the receiving party.